Hereby I open this academic ceremony in which Fatemeh Janesarvatan will defend the academic thesis Rooted in Reality, Virtual Patient Simulations in Dental Education. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you very much, dear Prorector. Hello, everyone. Good morning. And welcome to my PhD defense, especially to the members of the committee, my supervisors, dear family, friends, colleagues here and online, Maman and Baba. In the next 15 minutes, I will present a summary of my dissertation entitled Rooted in Reality, Virtual Patient Simulation in Dental Education. But before going into details of my studies, technical issue. But before going into details of my studies, yes, sorry. I would like to introduce Sarah to you. She's in her 5th year of dental school at Tehran University and has just started seeing with pediatric patients. She passed her theory courses and completed 2 practical ones in pediatric, one working on psychomotor skills, working on the phantom heads, and other one working as an observer in the clinic. Now she's about to visit her first patient, but she doesn't feel ready or confident. And she's not alone. Research shows that 80% of final year dental students don't feel prepared or ready for clinical practice, especially in diagnosis, treatment planning, and communication with patients. Dental education tries to bridge the gap between theory and practice, but real-life learning is often limited, inconsistent, and implicit. There are many challenges. A shortage of diverse clinical patients, patient safety concerns, high needs for tutor supervision, and difficulties in planning. Part of the gap between theory and practice are related to these challenges. However, others come from how students train, which is too much focus on theory and lack of clinical practice. And when they do practice, the focus is mostly on psychomotor skills, not clinical reasoning or management skills. This creates a gap in training and leaves students unprepared. One way to fill the gap is through simulation. Virtual patients are interactive, computer-based simulations of real clinical cases. Learner can read or listen to a case, request tests, and make a diagnosis, and write a treatment plan, just like in real life. But despite their potential, there is still lack of strong evidence on how best to design and implement virtual patients. So more research is needed to connect virtual patient design with real educational needs, which links to this work. This dissertation aims to provide practical recommendations for designing virtual patients that support clinical reasoning and management skills, especially for complex real-life tasks. To do so, 4 studies were designed. First study identified the challenges related to clinical practice from the perspective of experts and novices. Second study was a literature review focused on identifying how well do current virtual patient design follow instructional design principles. Study 3 and 4 were connected and aimed to investigate how do students learn best with virtual patients from both cognitive and affective aspects. In the coming minutes, I will briefly explain the main findings of each study. The first study explored what dental students struggle with most in their clinical practice. Results show that transferring knowledge to clinic is not easy. The gap between theory and practice and the lack of integrated training leads to low confidence, communication issues, and common mistakes like poor behavior management and weak treatment planning. While some of these challenges are related to the complex nature of the tasks, others are compounded by the separation of theory and practice. This study provides the data required to develop a design blueprint for virtual patients by identifying the complicating factor and common errors, as well as other participants' suggestions. Building on the first study, the second study focused on how virtual patients are designed in other studies, specifically whether they follow solid instructional design principles. We used four-component instructional design model, which is designed for teaching complex skills to review existing virtual patient studies in dental education. By this review, we found that many designs include task variation, which is essential. According to the model, varied and authentic tasks help students transfer what they learn to clinical setting. But how these tasks are delivered, especially the choice of mode, also plays an important role in how effective they are. The review also notes that more than half of the studies embedded virtual patients into their training programs. Most studies did not clearly describe how they aligned virtual patients and integrate them into their curriculum. The review also showed that how important supportive information is to provide the background knowledge and strategies they need to solve clinical problems effectively. It can be done, for instance, through sequencing virtual patients after a lecture in a deductive approach or providing cognitive feedback and reflection opportunities. Procedural information, like immediate and cognitive feedback or corrective feedback or tips during a decision-making process, is also essential. It helps learners stay on track and correct errors. Overall, our findings show that while most studies included some instructional design principles, none of them applied the design principle in a fully integrated way. In other words, there is a lack of a strong structure and consistent approach to design and implementation of virtual patients. Based on the findings from the first two studies, we designed 4 virtual patients using 4CID model to give students a realistic whole task experience that supports their learning. Here is how model was applied. Learning tasks. 4 virtual patients created based on real patient scenarios with different complexity level. Each case had clear learning goals to assess a student's ability to write a comprehensive treatment plan. Supportive information, a lecture by an expert provided to review background knowledge, how to design, how to diagnose, recognize symptoms, and plan a treatment. In addition, cognitive feedback was included in the virtual patients and a debriefing session led by an expert after the VP. Just-in-time information, students could ask questions to an expert during the practice only when it needed. And in terms of the last principle, part-task practice, this element was not included in our design since the focus was on practicing whole integrated task. Following the virtual patient design, 2 experiments were set up to understand how students learn best with virtual patients. So, study 3 and 4 focused on 2 main principles: task complexity, simple versus complex cases, and learning mode, individual versus collaborative. We look at how these factors affect the students' performance, their learning experience in terms of cognitive load and time spent on task, and also their emotions. In our intervention, we had 2 main assumptions. Collaboration would help students perform better on complex tasks, and individual learning would help students perform better for simple tasks. However, the results partly confirm this. For complex tasks, students spend less time when working together, and for simple tasks, students were faster when working alone. These findings align with the theoretical premise of shared cognitive resources in collaborative settings. We didn't find significant differences in their performance scores between the groups. This suggests that the benefits of collaboration in complex tasks are not always guaranteed. They may depend on other factors, like how students perceive the task, how well they work together, and their teamwork skills. So, task complexity alone doesn't explain everything. Collaboration is influenced by a mix of personal, social, and instructional factors. The variation between students' task perception could be explained by the differences between task complexity and difficulty. Even though experts help define which tasks were complex or simple, students sometimes experience it or perceive it differently. Complexity is about the task itself, while difficulty is about how a learner experiences it and perceives it. The same task can feel easy for one student and hard for another one, depending on their prior knowledge or confidence. This tells us that how a task is designed is not enough. We also need to understand how learners experience it. That's why involving students in the design process or testing tasks with them can help make virtual patients more effective. Another key finding of our intervention is collaboration is not always easy. Even though collaboration has clear benefits, it does not always guarantee superior performance due to challenges such as learners' insufficient collaboration skills, low group cohesion, or conflicts within the teams. In our study, students had limited experience with working in groups or working with virtual patients. This likely made collaboration more difficult for them, especially for complex cases. For collaboration to really work, students need preparation, clear group roles, and maybe even more some training in how to collaborate. Our finding also highlights the complex nature of collaboration, as articulated by collaborative cognitive load theory. Working in groups can share the cognitive load and increase engagement, but it can also create extra load through miscommunication and group conflicts. For complex tasks, these social demands can outweigh the benefits, but for simple tasks, students often do better on their own because they can go at their own pace with less distractions. This suggests that instructional design model, such as 4CID model, can consider the collaboration as a scaffolding tool by peer support and or as a learning method to practice collaboration skills. To make it work, we need clear task structure, proper preparation, and support strategies so students benefit from teamwork without becoming overwhelmed. In terms of affective aspects, we found that collaboration on simple tasks enhanced positive activation, potentially by fostering support and shared achievements. However, in high complex tasks, collaboration reduced positive activation, perhaps due to the combined challenges of domain-specific problem solving and social interactions. Complex tasks demand coordination, communication, and trust, which can lead to frustration or conflict, especially for novices. Additionally, reduced feeling of autonomy and competency, along with lower group cohesion, may further decrease the positive activation in these scenarios. Regarding to the association between emotion and cognitive load types, we observed a positive association with germane load and a negative one with extraneous load, which indicate that increased positive emotion can relate to the more cognitive efforts invested by learners, and increased negative emotions can relate to higher extraneous load, where learners are more likely to be distracted or overwhelmed by irrelevant factors. To conclude my presentation, I would like to highlight the key takeaways. The 4CID model aligns effectively with virtual patient design in healthcare education, offering a structured framework for creating authentic whole task learning experiences. The second one is different configuration of task complexity and learning mode can apply in various sequences. However, the challenge lies in selecting the right approach at the right time to align with the learner's need and the instructional context. If collaboration is a means of scaffolding, recognize its dual effects on cognitive load. To mitigate potential overload, consider pre-training for students in collaboration skills and adjusting task complexity accordingly. If collaboration is a learning goal, treat it as a complex skill and apply 4CID principles to structure its development. I would like to thank you for your attention and give the word back to the prorector.
Thank you very much for your clear presentation. It's now time to start with the opposition. And the opposition will be opened by the chair of the assessment committee of your thesis, Professor Joosten, Professor of Learning and Assessment at Maastricht University.
Thank you, Prorector. Dear candidate, congratulations with your great work. Your research identifies gaps in the transfer of theoretical knowledge to practice and proposes a bridge to bridge these gaps with a structured instructional design model, the 4CID model. And your thesis offers practical recommendations for optimizing virtual patient design and emphasizing the importance of adapting to learning needs, a better understanding of task complexity and emotions, and the dynamics of collaborations. So very well done. However, I'm not here for the compliments, but to discuss with you some aspects of your research that I would like to know more about. To start with the practical value of your research, I would like first to discuss the practical feasibility with you. One recommendation in your dissertation is to start with simple individual tasks and move on to complex collaborative tasks and then go back to the individual tasks. And I think that sounds very logical, but how practical is it to implement this in a curriculum with limited time and resources? And how is the transition then from the collaborative to the individual work on the complex tasks shaped? How does it work? And so I'm wondering, in a regular curriculum, bachelor curriculum, what kind of changes should be made in a curriculum to make this happen?
Dear esteemed opponent, highly esteemed opponents, thank you so much for your compliments and kind words, and also for your question. Regarding the practical value and how we suggest to apply, if we call it kind of strategy, to start the task with at individual level, to bring autonomy or to develop autonomy for students, and then when the students get it, start with more complex tasks with collaborative setting, so they can also practice they can practice the complex task and benefit from the shared cognitive load or shared resources, while they also can practice collaboration together. And then as the ideal, the end goal or the ultimate goal is to prepare for students to be prepared to work on the task by themselves, so individually. So it would be ideal if they have the opportunity to do that. But to see how it happens in for example, in dental curriculum, I think it can implement it because for the setting, for the context that we did research, it's more individual setting, and then students will go to clinic to do the practice. But when they go to clinic, they need to collaborate with each other. They need to collaborate with other clinicians, with assistants, and other experts and specialists of the field.
Yeah, so there's more time needed in the curriculum for the collaboration part, but where can we find this time? Is there, and how much time does it cost to get
yes,
this?
It definitely can need more time. But considering, I think, the benefits, I think it would be the trade-off between giving them opportunity to practice it before going to the clinic and start collaborating there. I think it would be beneficial to give them the opportunity to practice in pre-clinic. So before going to the clinic, they can have time to practice these skills, and then when they went to clinic, I think the learning could even faster their continuous
so it costs more time in the previous years, but you gain time for the later phase. Okay, thank you. And I would like to continue with a few questions about the design of the virtual patients. Study 1 identifies complicating factors and common errors. And study 2 assesses the application of the 4CID principles in the VP design. And although your thesis states that the VPs were developed based on the 4CID and input from study 1, so based on study 1 and 2, I was wondering how detailed was the transformation of the qualitative findings of experts and novices into concrete design elements within the VPs. So is there an explicit link between the identified complicating factors and the specific 4CID components in the VPs?
Yes. Thank you for your question. First study, in the first study, we identified the complicating factors and the common errors from the perspective of novices and experts. Yeah. And then we look at the already designed or existing design of the virtual patient in the second study to see how they apply the instructional design principles for designing their VPs. And then when we wanted to design our virtual patients, so we used the input from both studies. And how we implement the input from experts and students, we used the real patient scenarios and then consider all that elements can complicate the situation for novices from the both perspective, from students and also experts, and we include them into the practice. We focused mainly on clinical reasoning aspects. First, we also aim to consider management aspects as well, or management skills as well. However, we included in 2 of our cases. So we have 2 cases. We designed 4 cases in total. 2 of them focus in clinical reasoning aspects, and 2 others, which were more complex cases, combine clinical reasoning and management aspects. And but when we wanted to design it, first we had other ideas to bring it more immersive or with a higher fidelity, adding some video records, but then the COVID came and we had some practical issues for our design. So we decided to go for more pragmatic approach, and then to keep it in a lower fidelity, and then combine all the factors together.
Okay, and now we are a few years further, so COVID is hopefully behind us. And suppose you had a time and the money to conduct follow-up research. Would you change something in your research, or what research methods or designs would you like to use in also to unravel the relationship between the emotions and cognitive loads, what is mentioned in your later studies? So if you had the money and the time,
Yes,
what would be the next step?
Thank you. That's a great question. It's a very interesting one. If I had time and money, which I'm not really sure with this kind of budget, because how would possible, and if the other pandemic will came or not, but I would definitely spend more attention, because for the first study, we include also students' perspective to the design. But when we wanted to design the virtual patients, we just used their inputs, but we didn't involve them in the designing process. So I would definitely, if I want to design another round of virtual patients, I would definitely involve students in our design process. And also, I would definitely go for more iterative piloting, so we can see how students can perceive it. Because it's one of the findings, I think, the key findings of my study is, while the complex cases were well calibrated with the experts, but the students perceived it differently, and it shows in our qualitative results.
Very nice ideas, and I give the word back to the pro-rector. Thank you.
Thank you.
Thank you, Professor Joosten. The opposition will be continued by Professor Kals, Professor of Educational Technology at Heidelberg University of Education and the Open University in the Netherlands.
Thank you, Pro-Rector. Dear candidate, first of all, congratulations. I really enjoyed reading the thesis, and especially the methodological richness in it made it very enjoyable to read for me. Thank you very much. I'm referring in my first question to Chapter 2, the first study that you presented, a qualitative study based on the perspectives of experts and novices, which had the question, what aspects of practical importance are critical in dental students' learning of clinical management, clinical reasoning skills? The goal was to identify typical errors of dental students in the clinical management, clinical reasoning. Yet the students only had 5 cases of primary pulp treatment during clinical practice before this study. And you conclude, due to teaching methods that focus mainly on theoretical knowledge, most graduate students do not have enough self-confidence and communication skills when interacting with patients. I'm first interested how different the perception of the experts was compared to students. You explained that a little bit in the chapter, but not so extensively. That's the first one. And the second one was that the identification of these issues did maybe depend more on the lack of practical experience. And then it's a question, is it really a didactical challenge, or is it just the amount of practical experience that makes a difference? And how would a real integrated practice look like, that it really benefits from each other, so theoretical knowledge and practical knowledge?
Highly esteemed opponents, thank you so much for your compliments and kind words, and also for your interesting questions. Regarding your first questions about how, what was the difference differences between the perspectives of novices and experts in terms of factors complicating the situation for novices. It's a very interesting question. However, it wasn't the ultimate goal of the study to compare their differences. We were interested to see what exactly make the situation more difficult for novices, and then we decided to have it from the both perspective. They did have a different perspective. For example, as experts, they were mentioning that novices mainly missed having a more comprehensive approach to the treating a patient. So they focus too much on knowing what is the diagnosis for this case, what is the indication, what is the contraindications of the case, how I can interpret the graphic. So they focuses on these aspects, which are the steps of doing writing a treatment plan and making a diagnosis for the patients, but still having a comprehensive approach is the ultimate aim. Because even when they do diagnosis and they follow a procedure, they also need to consider many different aspects of the case, the background, the socioeconomical situation, the family, the hygiene, health, and many other things. If there is any historical background in the family, they also need to consider that, but they mainly missed it due to the lack of experience. And from the students' perspective, they were too much focused on more management aspects of the case, how they can make the trust, how they can make the connection, and how they can interact with the kids, with the child. Because, for example, most of them, they're really scared because the child also is scared, and the parents also worry. And you know, managing this, it's very difficult for novices. And I think it's also kind of related to your second question, to identification how these factors could help them to bridge the gap between theory and practice. So one of the main, I think, reasons for this is lack of the practice, because the students, the curriculum they have, it's more theoretical basis. So they have 2 theoretical bases, they have 2 practical one, but the practical one is mainly focused on procedural skills, psychomotor skills. So it's like they're working on the phantom head, on the tooth pulled, and they just do drilling, making a hole and filling the tooth. And the second one is just doing, acting as an observer in the clinic. But when they go to clinic and they wanted to visit the first patients or the first encounter with the patients, they're not really ready for that, but because they really miss the practice time. And without, it's the very well fitted if virtual patients can provide this opportunity or an experience for students before going to the clinic to practice it in advance.
Thank you. Would you then say that the theory does not cover the practice sufficiently, or that students did not do the transfer?
I think both. It would be both. It's mainly, I think, resulted from how they trained, of course, because and I think it's mainly because of how they train, because too much focus on the theory, and they're novices, so they really have lack of experience. And I think it's understandable that they cannot do this transfer very well in their first encounter, and a virtual patient can help them because it can increase their experience and their encounter with patient, even virtually. So they're not really facing something that they didn't experience in advance.
Do you have any suggestions how an integrated educational model would look like that takes theoretical knowledge and applies it into practice and also reflects it back again? Is that what ForceID does? So is that...
I think, I think ForceID model, it's, to my best of knowledge, is one of the models that designed for integration and coordination of complex skills, knowledge, skills, and attitudes, and it's very well fitted, especially for complex skills and also in healthcare situation, because students, when they go to a clinic, they need to do the complex tests usually, and they don't have enough experience. And I think the model provides not only the instructional principles, but it also provides the steps, very detailed steps on how we can design the task or how we can design the program in a way that prepares students, so students have different opportunities, many opportunities to practice with varied, authentic cases based on real-life cases, and also practice them with different sequences, with different supportive information, and also with all the elements and also steps.
Thank you. Prorector, do I have still time for one more question?
No, I'm sorry, no more time. Thank you very much, Professor Kalt. The opposition will be continued by Dr. van Gerven, Associate Professor in Structural Design, Learning and Memory at Maastricht University.
Thank you, Pro-Rector. Dear candidates, congratulations on this great achievement. And with this, I would also like to include your supervisory team. Your dissertation reports on a balanced set of studies aimed at an optimal design of virtual patient simulation in dental education. That sounds familiar, right? I'm sure your research is not only relevant for dental education, but also will reach far beyond that, I'm sure. But now my questions, and let me start with the main title of your dissertation. It's Rooted in Reality, it says, right? Rooted in Reality. I'm sure that this reality includes many technical, clinical, and management skills that a pediatric dentist needs to master and that may look slightly different in reality than it does in an educational setting. However, I would especially like to explore with you the social reality of a pediatric dentist. If there's one situation in this context that I cannot get out of my head, then it is that of the non-cooperative child that you introduce in chapter 2. You bring that up as a main theme in your qualitative study. I refer to chapters, by the way, not to studies, so hope that is not confusing. Different scenarios come to mind, from children that just cry or yell, to children that clench their jaws, imagine that, or become downright aggressive. I'm not sure whether that happens, but I could imagine that. I'm not sure whether I should classify these situations as routine or non-routine in 4CID terms, but it is something a future pediatric dentist needs to deal with in some way or another, and probably on a regular basis, right? I also believe that it is especially this kind of situation that forms a challenge for students in their transition from an educational setting to the clinical practice. So I assume that before that transition takes place, that it is good to have some practice with that, with non-cooperative young patients. Therefore, I'm somewhat surprised to see that this social dimension of pediatric dentistry was not really incorporated in the virtual patient scenarios you used, especially in chapter 5, which focuses on affective states, in this case of the learners, right, of the students, and not so much of the patients involved. And to be honest, regarding chapter 5, I'm not surprised at all to see that the results of this study show that the learning task did not stir much emotion in the participating students. I suspect that this observation would have been entirely different if managing the emotions of young patients and their parents would have been part of the mix. Although social dynamics may be hard to incorporate in virtual patients, as it stands now, I'm sure that you agree that it is definitely something to explore in the future. Now my question is, do you agree with this notion? And if so, which I hope, would you have any ideas for incorporating social aspects of pediatric dentistry into your virtual patients now or in the future?
Dear esteemed opponent, thank you so much for your kind words and compliments, and also for your very interesting question. Regarding your question, I totally agree with you, and I understand the concern. I think managing a child, especially uncooperative child, it's a very complex task, especially for novices. Mm-hmm. I do expect that even for some specialists and some experts, it's not even easy. And the way that the dental education or dental training programs, they focus, I think they really lack of a structured way to train even specialists how to treat a child, mm-hmm. how to communicate and collaborate with the child. And I think it's one of the missing parts. Mm-hmm. For novices, it's also very important and also very important to learn, and also very challenging task for them. We decided to don't include it in our design. However, we include it partially, but not fully. So the first idea of our design was we wanted to have even different cases just focus on managing a task. You might know Laurie Pitt, his pediatric in Maastricht in hospital, mm-hmm. and he has a fascinating work in how we can use management skills and behavioral management to control the situation, to communicate with the child, to interact with the child. We wanted to also apply it in dental, and I think if we do that, we would be probably the first study or first design that do that, but due to the COVID came and we really changed the plan. But it's also worse, it's very worse, I think, considering for future study, to focus on these aspects and also provide a guidance for students how they can use different management skills and behavioral skills for communication with the patients.
Yeah. So now I'm curious about the technical possibilities, right? I'm not sure whether you are familiar with that or whether you can say anything about that. I'm a total nitwit in that regard. So suppose, for instance, this mannequin that you showed in your presentation, can it clench its jaws, for instance? Or can it become a little bit restless or whatever?
Yeah, I think there are some, developments in this area, but still, I think emotional design, I think it's not a different field, but it's a little bit, I think, different approach, having really different approach. So more immersive design, how they can really react to the questions. It was also one of the suggestions during the interviews we had with the students. We asked them how they perceive the virtual patient, how they perceive the fidelity and also the realisms of the case. And they found that, however, it's even though the cases were very simple, so we didn't implement or add any of these kind of emotional aspects to our design, but the students really appreciate the experience because it kind of represents, because it was a whole task experience based on the real patient scenarios, it represents the real situation for them. However, some of them, they also suggest that if they have the opportunity, for example, when they're asking a question from a patient, the patient can also react, for example, scream or start to cry. It would be also more beneficial for them. Of course, it's more challenging, but it would be more close to the real situation.
Yeah. So back to the possible techniques, right, that could be used. I'm also thinking along the lines of like virtual reality or artificial intelligence. I mean, there's a lot to do about that, of course, recently, and developments go very quickly. Do you see any developments in that direction that could be helpful in this regard?
Yes, definitely. Yeah, there are many developments, I think, in this field. Less in dental education, but more in medicine and also in health professional education in general.
Yeah. Did you consider that for your project?
We did not consider it, but I think there are possibilities to.
But regarding the non-cooperative child, right, which was one of the main themes, and I could imagine that this is one of the most challenging ones, right? Did you imagine in any way to incorporate that in your cases?
Yeah, we did not really go and delve into it for our design. It was one of our first ideas to have.
The first theme that is mentioned, right?
Yes, exactly. Yeah. But we also found it challenging to include it because we need to have different media in that way. So more immersive or more with a higher fidelity, at least, to be able to represent the situation. And we thought these students are novices, and I think the task itself is complex enough for them. So I think we decided to just keep the complexity as it is. And then leave it for the other parts of their training, maybe for the later higher stages. Level, so they could have opportunity to practice that one.
Okay.
Yeah.
I think we need to... Yeah, time's up. Okay, give the word back. Thank you.
Thank you very much, Dr. van Gerven. The opposition will be continued by Dr. Rusman, Associate Professor Seamless Learning at the Open University of the Netherlands.
Thank you, Chair. Esteemed candidates, dear Fatemeh, first and foremost, congratulations for this interesting thesis and also, of course, for this opportunity to question and challenge your work. Maybe even your study has come into hand while preparing for this complex task or defending your thesis, and you're doing great. So my first question is actually about your first empirical study, which is described in chapter 4. And you study the relationship between complexity of task and carrying it out either individually or collaboratively, and how this is influencing the task, the time on the task, the cognitive load, and the task performance. And your expectation was that complex tasks can best be learned collaboratively, as the complexity is divided across the students and thus can reduce the cognitive load. However, looking at the results, you didn't find the expected differences on performances, however, only effects on time of task. But you give the advice for a strategy of designing to start a set of tasks on a given complexity level, always collaboratively. And I was a little bit puzzled with this advice, frankly. So I was wondering, could you maybe explain me a little bit further for this? Because I would assume that collaboration itself may also actually add to the experience extraneous cognitive load, depending on your learning objectives, and also maybe add to task complexity, because it's an extra thing that you need to consider while performing and carrying out the tasks. So could you explain this advice further to me, looking at intrinsic, extraneous, and German cognitive load, and also in relation to the outcomes of your study, please?
Dear esteemed opponent, thank you so much for your kind word and compliments, and also for your interesting question. I understand the concern. I think we didn't find really the differences or significant differences between groups because we expect that when students collaborate on high complex tasks, we expect to have a better performance or higher level of performance, spend less time, and also lower cognitive loads. But the only parts we find significant difference, it was time on task, which is an important aspect of doing clinical practice. Especially in pediatric dentistry, it's very important because they also need to do the task. It's as much as possible, not in a way that to just fast doing or finishing the task, but it's also be very selective on the question that they might ask, because they all know that, and they are very well aware that at certain points, even with a cooperative child, they can lose the cooperation. If the child gets bored or I don't know, scared or something happened during the practice, they can miss it. So it's important, I think, of course, that I did not, although I didn't really find the differences in performance and also in a cognitive load scores, but still the results or the findings regarding the improving their time on task, it's still valuable. And it's also lead us to provide that suggestion to start a task for complex tasks collaboratively, but we also put the emphasis that it's very important to prepare students for that collaboration and also design the collaborative task in a way to avoid bringing extra load to the team or to the group. Because, yeah, that's true. It's, the collaboration has benefits for students because they share the resource together, they communicate, they brainstorm together, they can challenge each other because it happened during the practice. I was the observer of the intervention, and they constantly challenge each other, ask each other, share knowledge together. But it's in the situation, and it's worked perfectly when the group cohesion is nice and well. However, when students cannot really collaborate with each other, and when they're not really trained how to collaborate, or so the group cohesion is not really well designed, or students cannot really reach an agreement on a case, it would be more challenging, and it's definitely add extra load for students and can decrease their performance.
Thank you. I would like to follow up on this because, as I understood from your study, you recommend actually when you have more complex tasks to collaborate. But in the same time, in the same chapter, you also state that in each given task class, you would recommend to start with a collaborative task. And this seems contradictory to me because you also start with lower complexity task classes and you build, of course, like in the jigsaw model of the 4CID. So how should I interpret this? Because the low task classes, it seems that you give them the same advice, although the task complexity is not as high there. So could you explain that further to me as well?
Yes. The recommendation about starting the task the high complex task in a collaboration, it's come to we put the emphasis on if we consider the collaboration as a scaffolding or methods or a supporting a tool, it would beneficial for students because due to the peer support, they can support each other, they can share the load together, and in that way it could work. But if it's if the goal is to practice collaboration as a skill, I think we need to approach it differently.
Okay. Do I have time for one more question?
Yeah, 2 minutes.
2 minutes. Okay, great. I was wondering, in your study you practice 2 weeks with patients, and I know that mastering skills requires a lot of practice and a lot of time. And I was wondering, and you don't implement corrective feedback, you do implement cognitive feedback. And I was wondering if you would include both types of feedback and you would plan for a longitudinal study. How would you think this would impact your study results?
In terms of corrective feedback, we also had corrective feedback for students, but it's also, I'm not really sure to say corrective or cognitive feedback because...
To me, that actually was more like cognitive feedback because students had to ask for it. And if you ask for it, you know you did something, and then it's a bit different than the past task, practice of, and where you are actually getting corrective feedback on the task you perform right when you are performing it. So
yes, but we also had the corrective feedback because when students follow the different steps, so they had, for example, taking the history, pain history, medical history, dental history, and after each steps, they receive a feedback. We provide a table, so students could see what question they choose, and we provide, like, for example, number 20 question per each step. So students could go over all the questions, all the possible questions, but they could be also selective due to the situation, and also thinking about don't losing the cooperation of the child. So they could be more selective about choosing the task. And at the end of, after each step, we provide a table which shows them what question they choose, and if a specialist or expert do the interview with these patients, what type of question they choose. And after that, we also explain what is the reason behind these choices. So students could reflect on that. And at the end of the program, we also provide a summary of all their choices and also supportive information, like detailed information about the diagnosis, about indications.
That's more like the cognitive feedback, But to my main question, so how would you expect like a more longer period of time would have influenced your results?
Yeah, that's a very interesting question. I think it would definitely have...
Can you try to give a short answer?
Yeah. I hope so. I think it's a very interesting question, and I think it's value to research for future works to see how the impact could also, continued or stayed with the students even in the clinic or a couple of months later or even in a longer periods. Yeah.
Thank you.
Thank you, Dr. Rosman. We come to the last opponent. It's Dr. Rende, the Assistant Professor of Skills and Simulation Education and Presenting Under Pressure at Maastricht University.
Thank you. Dear candidate, first of all, I would like to congratulate you on the successful completion of your thesis. My compliments to you and your supervisory team for the quality of the work and the clear structured way in which you have presented your research. I'm pleased to take this opportunity to engage with you in dialogue, and I would like to begin with one of your propositions. So I would like to ask one of your paranyms to read proposition number 8.
Collaborative learning does not inherently lead to better outcomes. Its success depends on design alignment and learner readiness.
So you argue that collaborative learning can be beneficial, but only under certain conditions. Could you please elaborate on this point? And in your answer, I would like to explain what you have learned from your data in chapter 4 and 5 about how students experience complexity and collaboration. Based on those insights, what would you say are the key ingredients for making collaborative learning in virtual patient environments successful?
Dear esteemed opponent, thank you so much for your kind word and compliments and also for your interesting question. Regarding the findings of my intervention about collaboration, how students collaborate with each other, as we had two main assumptions, that we expect the students perform better when they collaborate on high complex tasks, but we really didn't find the differences. We just find the differences in their time spent on the task, but we didn't find the differences on the scores, on the performance score or cognitive load, which was also surprising for us. And to find the reason, we also had, hopefully we had the qualitative aspects. So we try to look at or qualitative data to see what would be the reason behind it. And one of the main reasons, I think, from this, from my study, of my intervention was our students, they had really limited experience with collaboration. So their whole program or whole curriculum, it's more expository, I think, curriculum. So they don't really train how to collaborate. They don't really train how they should work on a task. They do work on the clinic, and they do that in their own way, but it's not something really structured or instructed to them. And they also had limited experience with virtual patient. They had actually no experience with previous virtual patient. It might also has impact on the results. So thinking also about the other possible reasons was also more related to the collaborative skills, to communication skills between the students, about the group cohesions and the conflicts that they have, because our qualitative data is polarized. Some students really appreciate the collaboration on the high complex task, and they also mentioned that it's beneficial for them, but in some other groups of students, they were really against it, and they thought they could work better on this task individually.
Is that necessary for the job anyway? Because especially with a stressed child, it's useful to collaborate with the parents. So collaborative skills are important for the job anyway?
I think, yeah, it's for sure it's important for the job anyway. And it's not just coming to the collaboration with the parents, it's also collaboration in the clinic, because, and also with the child itself, I think. Because when they go to the clinics, they're just not working on a child by themselves. So they need to collaborate with other colleagues as well, with other specialists, and also assistants. So they really need to practice on it.
Thank you. Because of the time, I'll go to my next question. In chapter 3, you explained that your study excluded research on psychomotor skills, and that your virtual patient simulations were not designed to support the automation of routine tasks. Now, considering the 4CRD model, I would like to ask you the following. Could you argue from that perspective of the model why the motor execution of pulp treatment might be considered a routine task that would benefit from part task practice? And conversely, could you also reason why it might not be a routine task and thus might be still require whole task practice and supportive information?
Dear esteemed opponent, I think could you please reflect on your question? Because I think I did not really...
You excluded motor tasks.
Yes.
So considering the 4CRD model, could you argue that performing on the motor level, the treatment of the pulp treatment would be considered a routine task and need part task practice, or given the circumstances in which you have to perform it, would you consider it a whole task practice and would be needed supportive information?
Yeah, I think practicing psychomotor skills, I would say I would consider it more routine aspects of the task. But they really need to practice to be competent on it. So it could consider, part of the program or design that they can also include it and implement it in the design in the 4CID. But they can do this practice, for example, in the phantom head and or in the two-spooled as they do in their regular practice.
Okay. As a follow-up on that, do you believe that virtual patient simulation could be meaningful extended to support the training of the actual psychomotor execution of pulp treatments?
It could be because there are, but it needs really different design. Because, for example, there are...
You want to shortly finish your answer?
Yes, please. Thank you.
Go ahead.
Because there are some other works that they focus on these aspects, but they have very different designs. So it's not really included as a whole task experience or comprehensive approach to the patient, but more just specifically practice that specific skills for example, drilling or filling.
Thank you.
Thank you very much. Fatemeh Janesarvatan, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and of your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road south side. 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. The mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Okay.
Fatemeh Janesarvatan, the time appointed for the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor van Roosmalen is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
All right, please. Dear Fatemeh, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
I do promise.
By the authority vested in us by law and in conformity with the decision of the committee, I hereby confer upon you, Fatemeh Janesarvatan, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with a degree certified, signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
Please be seated.
Maybe you can check whether your microphone is on.
Dear Doctor, or rather, dear Fatemeh, our warm and sincere congratulations with your PhD.
Please keep the microphone close to your mouth. Yes.
In the past year, the three of us had a successful and an enjoyable cooperation, and most important, you produced an interesting and a relevant thesis. In this period, you did a lot more work and addressed many more challenges than one could imagine by just reading your thesis. Your research journey mirrors your thesis. You dealt with complex tasks, individually and in collaboration, while emotions and stress were going up and down. Since reflection is a key to learning, we would like to go back with you over the past years and point to some of your highlights and challenges, not only in your research, but also in all the jobs you did. We will do that by metaphorically walk you through the 4 seasons, spring, summer, autumn, and winter. 2018, spring, the seeding of your thesis. Almost exactly 7 years ago, I was asked to follow up on an email to our department. In this email, you asked if it would be possible to do a research internship. We exchanged a couple of emails, followed by a Skype call, and discussed your interest. At that time, unbelievable if you hear you now, you were quite shy and a little intimidated by me. However, you were very clear about your interest in research for CAD virtual patients and what you wanted to achieve, a PhD. The result, at the end of August, you arrived in Maastricht, initially for just 9 months. However, your topic and your work spirit and enthusiasm fitted so well that we decided to offer you a possibility to start with a PhD degree. At the end of 2019, you achieved your first milestone. Your proposal was approved. 2020, your first results, but also the first challenges. Unfortunately, the start of your PhD was also marked by the start of COVID. It did bring a dark shadow over your personal life. You were far away from your family and close friends, without the love and comfort, and all kinds of worries. It also affected your research, limited discussions with peers, no conferences, and you had to adapt your research in line with the restrictions and all the uncertainties that would follow. Still, you were persistent, and our discussions were always positive. And we really discussed a lot. Not just your research, but academic habits, politics, old Dutch traditions, Maastricht versus Tehran, and obviously the wonderful Dutch weather. And apparently, I'm not sure how that helped, but the very broad scope of our discussions prepared you well for in the following years. You were very productive. You completed your first studies on interviewing students and staff, and your second study on literature review, and you learned by trial and error how to prepare an article in line with all those horrible academic journal requirements. And important to notice, already in that period you started to broaden your scope. You joined a SURF project for medical Dutch. Building on all this knowledge, you did, however, meet the next challenge, how to build a virtual patient. When needed, the support in Iran was not available, so you had to do it yourself. One good thing came from this. You did get in contact with Jimmy, and at the end of the year, Jimmy officially joined our team. And to also show the audience how well you integrated in the Netherlands, I'd like to share some small anecdotes from Jimmy. It was about visiting the Eco Spring School. And adapting to the Netherlands obviously also means adapting to the expectations of the Netherlands. At a party, Jimmy's story, during the Eco Spring School, I wanted to put earplugs in for my hearings, to warm it up and make it fit a little bit better. I breathed it on the earbuds before using them. You came to ask what I was doing. And I said something about earplugs. Maybe you were also wearing earplugs because you understood something about drugs. So that evening, a group of people thought that I had put something into my ear, other than earpuds in my mouth. Fortunately, it was clarified the next morning. Autumn, rounding up and almost there, 2023. In 2023, you did once more broaden your scope beyond your PhD. You successfully applied for a part-time position for a Comenius project for the toolkit for the Bachelor of Medicine. You made an active and well-appreciated contribution. For the experimental part of your research, you traveled to Iran. The experiment should cover 2 studies at once. Since at that time, COVID was not yet stable, and it was difficult to travel to Iran. The virtual patients were received very well, both by staff and by students. However, the patterns in the data collected were not easy to read and did not directly align with what you had expected. You had to deal with difficult choices on how to go forward, and you had to invest a lot of time in deepening your knowledge and skills of statistics. Here, Jimmy and I would really like to compliment you on your perseverance on probably what was the most difficult stage at your PhD. Nevertheless, at the end of 2023, you were very close to finalizing your 2 experimental papers, and you had started with your introduction. 2024 became a long winter. Winter is traditionally the time to relax and to think over one's achievements and to think what to do next. In line with this, at the beginning of 2024, you were very optimistic and expected to be ready to submit very soon. However, you didn't want to relax, so instead, you prepared already for the future. You opted for an almost full-time project position of the School of Business and Economics. And your work there was and is still very much appreciated. I have some quotes to show the appreciation of your work there. Fatemeh had to take over ongoing work and also familiarize her with a new domain. She did both with verve. She quickly proved to be the driving force. Fatemeh, another one, is a driving force in bringing people together within our group. She likes to talk to others. And the last one, she's persistent, but in a friendly way. She has a clear idea of what she wants, but is not pushy. And last but not least, not an easy one, but in the meanwhile, you also did your inburgers exam. Back to your PhD. Unfortunately, the last 5% of your PhD did cost much more effort and time than estimated. The final details force you to dive even deeper into it and rewrite part of your findings. For a very short period, it looked like the complexity really overwhelmed you. However, finally, you did address all the issues well, and now we celebrate the outcome. With your thesis, alongside, which you can be proud of, 4 project positions, there is nothing left more than to applaud for you. Thanks for the journey, it was wonderful. We look forward to hearing from you and all your new experiences.
Thank you. Dear Dr. Janesarvatan, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I also would like to congratulate your family, friends and colleagues here and probably also online with this beautiful achievement. I'd like to congratulate your supervisors. I'd like to thank the members of the degree committee for the time they have invested in preparing for this ceremony and being here and the lively discussions during the PhD defense. And I'd like especially to thank Professor Karls and Dr. Rusman from outside Maastricht University. Your contribution is very much appreciated by the university. I hope you also enjoyed the ceremony, and I wish you a lot of success in your future career and to start with an enjoyable day. And with this, I close this ceremony.